Chapter 6 is about bones and the skeleton. And the first thing we want to really know about bones is that they come from cartilage. So if we look at this particular skeleton, we would consider this an adult skeleton, and we look at places throughout the skeleton that are still cartilage. Keep in mind, again, all the bones originated from cartilage, but there's still a significant amount of cartilage remaining in the skeleton after bone growth completes. So the blue stuff is hyaline cartilage, and that's what most of the bone originated from, was hyaline cartilage. There's also elastic cartilages and fibrocartilage scattered throughout, but the far most common type of cartilage in the system is hyaline, and again, that's because it was part of the bone making process. If we look at the places where we find hyaline cartilage remaining in an adult skeleton, we pretty much find it at the end of all the bones. So anywhere where there's a joint, one bone connecting to the next, we're likely going to find hyaline cartilage there as a remnant of that bone growing process. It also helps to lubricate joints and be somewhat of a cushioning function for the joint, so it's a good thing that it remains there. The costal cartilages, so the cartilage connecting the ribs to the sternum, remains as hyaline cartilage, and that allows for flexibility, so expansion and contraction ability of the rib cage, because the cartilage is flexible enough that it allows that to happen. We find fibrocartilage really in two primary places in the body, and one is the pubic symphysis. So that helps to hold the hip bones together in the front. Another significant place that we find fibrocartilage is the knees, so forming a deeper knee socket, and we'll get into that in a later chapter. In chapter 8, we talk about joints, and we also find fibrocartilage in between the vertebrae of the spinal cord. If we look at elastic cartilage, there's only a couple of places we really find that, and one is the ear. So your flexible outer ear is elastic cartilage, so it's sturdy, and all these cartilages are sturdy, but it's also flexible enough that it maintains shape while allowing flexing. The other place we're going to find elastic cartilage is the epiglottis. So up here with the lungs and the respiratory system, at the very top we find the epiglottis, and that's a flap of cartilage that decides, does this thing coming down the throat, does it go down the trachea to the lungs, or does it go down the esophagus to the stomach? And that's a really important decision to be made there, and so that cartilage carries out that function. Another general concept about bones is that bones consist typically of compact bone and spongy bone. And sometimes you'll hear the spongy bone referred to as trabecular bone because the individual little structures of the spongy bone are called trabeculae, but I will call it spongy bone and compact bone. So when we look at spongy bone, it literally looks like the inside of a sponge. Compact bone, as its name suggests, doesn't have any spongy characteristic to it, but it is a very dense, smooth bone. And let's not get confused about spongy bone being spongy. It looks spongy, but it is not readily compressible like you would expect a sponge to be, but its functionality is rather to provide a great deal of cross-bracing support without the extra weight. So having, in this case, perhaps 80% of the bone being spongy bone greatly reduces weight while actually increasing strength. So if the entire bone was compact bone, it would be much heavier and would actually be less strong. So it's sort of a 2-for-1 special. Decrease weight, increase strength, everything works out nicely there. This just happens to be a slice of skull, but really all the bones in the body are going to be this. So if we look here at a long bone, and remember from your reading assignment that long bones are those that are longer than they are in any other dimension. Typically we find long bones in the arms and legs. So a setup of a long bone, this happens to be a humerus, so the only bone in your upper arm. But the long bones are going to have a couple of different pieces to them. And the first piece here in the middle is the diaphysis. And the diaphysis is the shaft of the bone. So the long part of the bone is the diaphysis, and then the ends of the bone are going to be the epiphyses. So one diaphysis and two epiphyses for each long bone. And what we find when we slice a long bone open is we find on the outside we had compact bone, on the inside we had spongy bone, and that was no different from the skull bone we looked at a minute ago. But in long bones we also find a cavity. So the actual core of long bones is hollow and is typically filled with bone marrow. And there are a couple of different flavors of bone marrow, but the point of bone marrow in this case really is to be involved in making blood cells. So making red blood cells, making white blood cells, that's the primary functionality of this bone marrow. Somewhere in the book, I think it still says that bone marrow is a energy reserve, so a fat storage location for future energy source, and that's not really accurate because that's not its primary job. While it could do that, it's more involved in making blood cells. But that core is lined with the bone marrow, and then around it you're going to have a layer of spongy bone, and then on the outside of that, compact bone. And what you can start to see here is that bone actually has a significant blood supply. So bone is a living tissue. And because it is a well-vascularized living tissue, it's very good at repairing itself. If you've ever broken a bone, you appreciate the fact that it repaired itself, and probably with minimal intervention from the doctor. If you crush a bone, that would take a lot more work on the doctor's part, but for the most part, the doctor is concerned with lining it up and leaving it alone and letting it fix itself from there. And that typically takes around 6 weeks or so, again, because it has a good blood supply. If it didn't have such a good blood supply, then it would take much longer for healing to occur. We start to see here the individual units of bone, and we'll get to those in just a second. But within bone, we're going to have 4 different kinds of cells. The osteogenic cell here in picture A is the original stem cell for bone. So when bone first starts to form, the osteogenic cells were there doing that. They were the precursors to the bone. Osteoblasts are bone builders. So they actually build bone tissue. They put mineral, calcium and things like that, into the bone, building it bigger and stronger than it was before, or perhaps being involved in the repair process. Osteoclasts, picture D, are bone-breaking cells. So the osteoblasts built the bone. The osteoclasts can tear it down. And one of their primary functions is to remove calcium from the bone and put it back into the blood supply. We'll talk about in a later chapter how significant that is and what it's for, but for now we'll just say that calcium is essential for muscle contraction. And if you don't have enough calcium in your diet today, or this particular moment of your day, then the osteoclasts can take calcium out of your bones and put it into the blood, allowing normal muscle contraction to occur. They're also going to be involved in remodeling the bone. So as the bone grows, or if it's broken and repairs itself, it needs to be reshaped. And we'll get into the remodeling process here in a few minutes, but it's really helpful to keep the bone the right shape, the right dimensions and proportions, and also for the calcium as well. So we'll make a little bit more sense of that in a minute. Osteocytes, our option C here, are normal bone cells that maintain the bone, and basically once a bone is built, they are going to be found throughout the bone tissue itself, just living, staying in place, maintaining the bone, just doing normal everyday bone things. If we look at a single unit of bone, it's called an osteon. And what we find here is that besides calcium and other minerals, we also have collagen and some other structures that allow for the bone to have some degree of flexibility. Every time you bump into something with your arm or your leg, or any time you put pressure and twisting on a bone, doesn't necessarily mean the bone breaks. So the bone is not an inflexible, completely rigid object. It is relatively inflexible and fairly sturdy and solid, but it has some flex to it because of the collagen fibers here. So what we see is that we have collagen fibers running in one direction in the inner layer, running in the opposite direction in the middle layer, and then back in the original direction again in the outer layer. So 3 different layers of collagen there, and what that does is that allows for rotational strength. Because those collagen fibers are running in a rotational direction, that allows the bone to have a little bit of wiggle and a little bit of flex in those directions without breaking. But also because the fibers are running in opposing directions, it helps to solidify and to sturdy the system up. So it's somewhat flexible, but also self-supporting and self-stiffening. Through the middle of each osteon, we see here some blood vessels and nerves. So if a bone is damaged, it will bleed, as all damaged tissues will do. If a bone is damaged, it will hurt because you've affected nerve fibers there as well. And this is where our good blood supply comes from. So if we jump back to our previous picture here and see all of these over here, all of these individual little circular structures. And we can see more of those here, and in our pop out, these little circular structures here. Those are individual osteons. So they've got blood scattered throughout all of the bone tissue, nerves scattered throughout all of the bone tissue. So it's well supplied with blood, and it's well supplied with sensation. So here we can see that osteon popping out there, and the 3 different layers of collagen they've sorted out there. And then looking at the middle of it, we see the blood vessels and nerves popping out. If we look at a zoomed in view of those osteons and the central canal, or the opening where the blood vessels and nerves pass through, you can see here in this beautiful image from a nice expensive microscope, you can see the blood vessels sticking through there. Nerves are also there. They just didn't show up well in this particular image. The microscopes that we would use in the classroom, or the virtual microscope you're using in this course now, is not going to show that kind of view. It is rather going to show the view over here on the right. This is the same thing. It's just looking at it from a different level of magnification. So the dark spot in the middle here is where the blood vessels and nerves will come through, and here around the outer edges are the circular structures of the collagen, which we can somewhat see over here. The difference really between these views is our microscopes in the classroom would run just under perhaps $1,000 a piece. The microscope that took this picture on the left would run around $250,000 a piece, so obviously the more you pay, the better picture you get. Obviously, we don't have any of those microscopes. Let's talk about how bone forms and grows. And let's pretend this is going to be a humerus, let's say. At this point, we really can't tell for sure, but it looks like that might be that particular bone. Or it could be a hand bone. It doesn't really matter. The point is, over here in step 1, we start out as hyaline cartilage. So all long bones, and really most bones in general, start as hyaline cartilage and then become bone after that. And this is important not just for bone growth in the first place, or development and formation, but also for additional growth after the bone is formed and for the repair processes. So we start out as hyaline cartilage in step 1. In step 2, the cartilage in the middle starts to deteriorate and decay, and in its place, those original bone cells start to form spongy bone. By the time we get to step 3, we've formed more and more spongy bone, and we start to have a blood supply grow in there to support these actively growing and living cells. By the time we get to step 4, we've been working on the diaphysis, so a key thing is here we start building the diaphysis first, and then later, what we call secondary ossification occurs. That is, the epiphyses start to grow and develop. So now we have the diaphysis growing towards the ends, or the epiphyses, and then we have the epiphyses growing towards the diaphysis in the middle. So at some point, these tissues are going to fuse together, and when they fuse together in the middle, bone growth stops. So this is what determines how tall a person gets, is when their leg bones and all the rest of their bones of their vertical skeleton, when those bones complete their growth, they fuse together in this manner. The epiphysis fusing to the diaphysis on each end, then there is no longer any length occurring in growth of that bone. So you'll see there at the end the epiphyseal plate cartilage. So at that point, those two components have not completely fused together yet, but they're getting pretty close. So at that point, vertical growth is probably slowing quite a bit. And once that epiphyseal plate cartilage is completely replaced with bone, again, bone growth stops. But this will always be a weak place because this bone joint here, this epiphyseal plate, doesn't become fully fused together bone. Rather, it becomes somewhat interlocking bone. So that means that it's a little bit weaker at that spot than it would be throughout the rest of the bone. And when we get to bone fractures a little bit later on, we'll see an epiphyseal plate fracture where the bone broke at that joint. So it will always be a slightly weak point. So we grew by having hyaline cartilage, slowly replace it with bone, and by the time we're done, we have spongy bone on the inside and compact bone on the outside. The trick here is, though, we never made compact bone. The only kind of bone that bone can make is spongy bone. So how did we get compact bone if we don't make compact bone? Think about that for a second and see if you can come up with any ideas. Remember, we were stuffing more spongy bone in the middle of that, pushing out against the cartilage, pushing out against the muscle and everything else wrapped around the bone. So we're jamming spongy bone in there against resistance. Perhaps at this point you're starting to wonder, is compact bone simply tightly compacted spongy bone? And that is the correct answer. So spongy bone, as it's stuffed in there, is spongy as it's made, but the further you push it out, the more compacting pressure it experiences, and by the time you get to a fully developed bone that is full size, the compact bone on the outside is just lots of spongy bone smashed tightly together. So compact bone is simply, as its name suggested, compacted spongy bone. If we look at this bone formation at more of a cellular level rather than a whole bone level, what we see here in step 1 is that we start to develop a little bit of bone cells there in the middle, surrounded by mostly cartilage. Then in step 2, we've started to form spongy bone. In step 3, we've got significant spongy bone occurring, and we've got blood vessels growing in. And then by step 4, we've got spongy bone surrounded by compact bone with lots of blood vessels and nerves through the middle. When we talk about bone growth, let's say the bone wants to get longer. And what we can do is we can have cartilage grow on the end of the bone, and we can have perhaps a little bit of cartilage growing there at the epiphyseal plate as well. But the point is, anywhere in this bone process that we grow more hyaline cartilage, it will be replaced with bone, just like it was to form the bone in the first place. So bone growth and remodeling is to add cartilage, replace it with bone, and then reshape. So if we look at the picture on the left, that was what our bone started as. The picture on the right, the red dotted line shows where the bone was, and then you can see where bone grew to replace. So everywhere where there is bone past that red dotted line was cartilage that grew, then replaced by bone. But you don't want to keep growing just this big round blob of bone at the end. Otherwise, the bone pretty much becomes a small diaphysis with huge, long, blobby epiphyses on each end, and you lose the proper shape. And these bones need to have the proper shape so that they properly interact at the joints. So what you have is bone remodeling. So what they're showing is that any of the spaces within that red dotted line that don't have bone at the end, but did have before, that bone has been shaved off. It's been removed. So the osteoblasts added the bony tissue to the ends to extend the length. The osteoclasts came along and shaved off the old bone that was in place that was no longer properly in place. So it reshaped, it recarved the bone as you go to keep the proper shape and to keep the proper dimensions so that the bone works properly. So again, osteoblasts build bone, osteoclasts reshape it and release calcium. So here's the reshaping part. The same idea will occur with a broken bone as it repairs, and we'll get to that in a few minutes as well. But bone remodeling keeps the bones the right shapes, the right proportions for functionality, even as they grow larger. So the growth itself doesn't maintain proper shape, it just adds mass. Osteoclasts have to keep everything shaped properly. And that's a continual process throughout life. Here's where that calcium regulation becomes of interest. Let's say your body wants to have calcium levels in the blood of somewhere around 10 milligrams for every 100 milliliters of blood. And let's say then that the blood calcium levels drop. So you haven't had much calcium in your diet today, perhaps. Your muscles are using it, and then you need to replace it. So because it's not coming in your diet, you have to go get it from bones. And behind the thyroid gland in your neck are 4 little dots of tissue called the parathyroid glands. And when parathyroid glands detect low levels of calcium in the blood, they release parathyroid hormone. When parathyroid hormone increases in concentration in the blood, that stimulates the osteoclasts, the bone breaking and calcium releasing cells, to go to work in that bone and pull some calcium out of it and release it into the blood. That then gets our blood calcium levels back up to around the 10 we were looking for, and once that happens, the parathyroid glands say, okay, we've got enough calcium, we'll stop releasing parathyroid hormone, life is now good. So this is one of those negative feedback mechanisms that we talked about at the beginning of your experience, that the end product here of increasing blood calcium levels turned off the stimulus that called for the calcium levels to go up. So we achieved the outcome we were looking for. The body says we've done what we needed, turn it off. And that was the whole point of negative feedback, was to get the job done that you need, and once it's done, stop, don't overdo it. If you get too much calcium in the blood, that can cause some problems as well, including ossification of soft tissues. And what that really means is development of bone tissue where there's not supposed to be bone tissue. So you can have bone fragments start to grow in the middle of muscles, and that's obviously of no value. It's actually quite painful and problematic. So hopefully this system would shut off appropriately and maintain those levels. Bones are there in the body to do a number of things, which you read about in your reading assignment. But right now we're talking about holding the body up, so supporting the body's mass. And let's say that I weigh, I stepped on the scales the other day, it was 243 pounds. So that means that in the femur of the upper leg here, they have to be able to support an incredible amount of weight. And you only have one bone in each side of or each upper leg, so one femur on each side. And that means that if that femur is going to hold, let's say 210 pounds of that body weight, that's a significant amount of weight. And each femur would then be holding 105 pounds, let's say, when I'm standing equally on both legs. But what if I shift all of my body's weight to just one leg? That means that femur is holding the full 210 pounds of the body from the upper leg on up, and that's a lot of weight. But it seems to do that reasonably well. So that is the ability of those bones to support weight. So it's really pretty sturdy considering its size and mass. But an interesting thing about the ribs here is, the femur, is that the body weight is placed here on the head of the femur. The actual load-bearing part of the bone here is the diaphysis, the shaft of the bone. So if we have the weight bearing here, but it's actually being applied out here, what we get is a twisting effect. So this dotted line here really is the direction that the force of the body is trying to make the femur go. We have stretching effect on the outside of the bone, compression effect on the inside of the bone here, but really the body is trying to take that femur and bend it into a C shape. Now it doesn't do that. The femur is, like all bones, slightly flexible, but not flexible enough to noticeably change its straightness. But there's a torsion, a twisting pressure occurring here on the femur. So the body really is putting all the weight out there on the head. So imagine you trying to take your textbook, hold it in one hand at full arm's length from your body. The weight of the book is trying to pull your arm down. Your body is trying to keep your arm propped up in the air. So that's the same kind of pressure and twisting that the femur has based on the body itself. So really we're saying the body is trying to break the head of the femur off, and we just hope that it's not successful. You know perhaps how much you weigh, so you would have some idea of how much force the bone has to produce, in other words, to hold you up. But think about a person, and you've no doubt seen people before that were more like, whatever your body size happens to be, more like 500 pounds, let's say. So someone twice my size. And you haven't met me in person yet, so you don't know what I look like, but I'm 6'1" and weigh 242, 243, so I'm by no means anorexic, but I'm not incredibly obese either. But double me with the same height, and now you're talking about a person that you then ask yourself, how do those bones hold up all that weight? And the simple answer is you didn't get to be 500 pounds overnight, so that meant the bones had a chance to catch up. So when bones are presented with a certain amount of strength they need to have to support you or to carry out whatever function you need, if they're not up for that right now, they will respond by getting bigger and stronger. So really the key to bigger, stronger, healthier bones is exercise. Put force, put pressure on those bones, and they will respond over time by increasing their strength to be able to support that pressure. So as a person gains weight, the bones slowly increase in mass and strength typically to support that. So a 500-pound person has probably spent years getting to that size, therefore their bones have had years to keep up with the demand and hopefully be able to support it. It does not mean those bones are completely happy with that scenario. So you still have increased risk of breaking and things like that, but within reasonable limits, bones will do whatever you need them to do as long as you give them a little bit of time to catch up. Perhaps you've heard of maybe Grandma or Great Aunt Judy or someone broke a hip. And this is one of the most commonly misunderstood kinds of things that happen to bones. So they tell you, I broke a hip. And they might actually say, I fell and broke my hip. I'm going to tell you that's not correct. Typically what happens with a supposed broken hip is nothing with the hip bone itself. Typically it's with the femur, and what happens because we have the weight being projected out here on the head of the femur, occasionally with the wrong twisting, with the wrong pressure and the wrong speed of pressure transfer, the head of the femur breaks off. So the neck there, connecting the head to the shaft, occasionally breaks with the wrong twisting and force applied. Then Grandma would fall. So really what happens was the head of her femur broke off, which then caused her to fall because that side of the body was no longer supported by the femur. Now when she was talking to the doctor, and the doctor was explaining what was going on, the doctor probably told her that she broke her hip. This is not because the doctor doesn't know what they're talking about. It's because they look at Grandma and say, she's old. She probably doesn't have a lot of anatomy and biology education. So if I use the phrase, you broke your hip, Grandma will have a good enough idea of what's going on to understand. If the doctor tries to explain, no, there's nothing wrong with your hip, you just broke the head of your femur off, no worries, we'll bolt it back on and off you go, Grandma would have a hard time understanding that. You might be inclined to try to educate Grandma and say, Grandma, no, you didn't break your hip. The head of your femur broke, then you fell, and that was the problem, and Grandma just won't get that. So probably not in your best interest to try to re-educate older folks. The concept of old dogs don't learn new tricks, well, that's somewhat true. But as long as you understand, most broken hips really are just a broken head of the femur. And probably what happened is Grandma was going up and down steps, and as she did so, she was hanging onto the handrail. The body was twisting, so you were putting additional full body weight onto the one femur, as you were also perhaps twisting going down steps or up steps, and that twisting plus shifting all the weight of the body onto that one hip went ahead and broke the head of the femur off. And then no support, then she fell. So now you know really the underlying concept of a broken hip here, mostly a femur issue, and the solution is usually to, well, you could bolt the head of the femur back on, or you could just do a hip replacement process. And depending on Grandma's health and overall condition and age, the doctor will have to decide what to do there. It's a pretty straightforward solution in most cases. So let's say we've broken a bone, and it doesn't matter which one we broke really. The process of repair is always going to be the same. So probably most of you have broken some sort of bone in the past. Maybe it was an arm or a leg, and you knew it. There was no confusion about what may or may not have happened there. You probably went to the hospital, you got an x-ray, and they said, yes, we can see, here's a picture of this broken bone. Some of you are thinking, I've never broken a bone before, and I don't believe that. Probably if you haven't noticed that you've broken an arm or a leg, you've probably still broken a toe. So if you've ever stubbed your toe really hard on something and you hear a loud popping, cracking sound, you immediately experience pain and discomfort, and perhaps you mumble some unfriendly for polite conversation words under your breath or to yourself. So that hurts. Perhaps it swells up, and perhaps it's tender for a couple of days or a week or two, and probably what you did was you broke or cracked a toe bone. And I think probably most of us have done that at some point in our lives. But regardless where the break occurred, it broke. Because the bone had a good blood supply in there, those blood vessels become damaged. When the bone breaks and shifts back and forth, it tears those vessels open, and you get bleeding. Now, normally for tissue damage, you want bleeding to clean out the wound. But we're hoping in this case there's no cleaning necessary. We're assuming this is a clean break, but it was a closed fracture. And what that means is that it didn't compromise the skin. So you don't have broken bones sticking up and out of the skin. Now, obviously, that's a possibility. It sometimes happens, but we're going to assume that that didn't happen. If that didn't happen, then you don't need to clean it. It's still contained within the sterile environment of your body. Obviously, if it did come through the skin, cleaning becomes relevant at that point. But regardless whether it comes through the skin or not, you're going to have this bleeding. And the important functionality of this bleeding at this point is that it sets the stage for repair. And basically, it's notifying the body, here's where the damage occurred, here's where you need to engage in repair processes. So step one, hematoma, basically large blood mass. That hematoma will convert to a fibrocartilage callus. So what that means is that it forms cartilage, and we'll probably have a little bit of hyaline cartilage mixed in here as well. So what it's doing is it's replacing all of the blood mass with cartilage, and remember what follows cartilage? Bone. So for bone to form, it had to have cartilage structures in place. So in step 3, we start to replace that cartilage with spongy bone. The spongy bone then basically connects the bone pieces back together again with bone. We eventually replace and carve down that spongy bone on the outside, get it compacted back to the form of compact bone, and so that's osteoclasts coming in and remodeling that bone lump at that point. So after a couple of years of breaking a bone, unless it was just a really nasty broken into many pieces kind of concept, you're probably not going to see any significant difference between that bone and a bone that was never damaged, because the bone is really good at reassembling itself. So I'm thinking an average break within 5 years or so, probably not going to be incredibly obvious on an x-ray even. Because again, your bones are good, and as long as you leave them alone and let them do their job, life works pretty well. In the olden days, if you broke a bone, you went to the doctor, and the doctor put this big concrete cast on it and then sent you off and said, come back in 6 weeks and we'll cut off the cast. In the meantime, you're packing around this large concrete mass on your body, and the point of that cast was to hold the bones in place while they repair themselves. The thought was you needed to immobilize the bone completely so that repair could occur. What we're now finding is that's not necessarily the best of ideas. What you really need to do is get the bone ends close to each other, support them gently, and leave them alone. What this does is it allows the bone to have a little bit of wiggle room so that it can correctly realign itself if it's off a little. So the doctor's going to try to set the bone, that is, line it back up as best as they can. But typically now, let's say you break your arm. Let's say it's the lower arm is a little easier to work with here. They're going to set it, so realign the bone as best they can, wrap it, maybe a little bit of a splint, give you an arm sling, and say, be careful for 6 weeks, then come back and we'll unwrap it for you. The thought there is get it close, let it fix itself, and do its own thing. If they put a cast on it and they don't get it realigned perfectly, then they might force the bone to grow back together a little bit crooked. Whereas if you left it a little bit movable, it would then allow that bone to wiggle itself back into position because the muscles around the bone will probably hold it and pull it together correctly, and then it would heal itself in a situation that would be more likely to be perfectly or properly aligned. Now, obviously, we can't do this for weight-bearing bones, so if you break a leg, they're probably still going to have to do the more of a concrete cast structure if you're going to walk on it, because you have to have enough support to actually bear weight on the concrete structures of the cast, not necessarily the bone as it's healing. So non-weight-bearing bones, we can just wrap, splint, and support. Weight-bearing bones still need to put a little bit more assistance into that process for that. So we can't completely eliminate casting of broken bones, but it's probably a good idea when you can to avoid that. If you break a finger, they'll simply give you a finger splint. Say, wear that for a couple of weeks and then take it off and away you go. So typically we're talking about a 6-week process from step 1 to good enough of step 4 to return to normal life. If you break it up worse than a standard break, it might take a little bit longer. So let's look at the different kinds of fractures. This is another one of those terminologies that is very misunderstood and misused in society. Often someone will say, I broke my bone, which they would then say it broke completely through. Or they might say, I fractured my bone, and what they're talking about there is a cracked and damaged bone that was not completely broken through. That's a misuse of the word fracture. Fracture simply means the bone is broken somehow, somewhere, to some degree. Whether it's cracked, whether it's broken all the way through, it's still a fracture. So all bone damages are fractures. So society has built a distinction between fracture and break that doesn't necessarily accurately exist. So we're going to talk about fractures. Just remember, that's some damage to the bone. In a comminuted fracture, the bone ends up in more than 2 pieces. So we didn't just break the leg and the top bone separated from the bottom part of the leg bone. We've got at least 3 pieces here and perhaps more. This kind of bone break is relatively common in older people, more so in younger people, because as you age, the bones get more brittle. That means there's more mineral content, there's less flexible collagen present in the bones, so they lose some of that ability to flex a little bit with impact. So the more inflexible something is, the more likely it is to shatter. So perhaps a comminuted fracture you might consider more of a shattered kind of bone. You can see in the drawing here we've actually got 5 bone pieces, maybe 6 that resulted there in that process. And in the x-ray you can tell definitely more than just 2 sections of bone involved there. In a compression fracture, this is a common thing in vertebrae because what you have is crushing effect to the bone. So it didn't necessarily just break in 2 pieces, but it's more of a crushed and perhaps a powdered kind of outcome. And this is relatively common in things like someone falling off of a ladder or falling off of a roof, and you land on your feet and you think, oh, that's a good thing. But what happens are the vertebrae actually bounce into each other, and in that bouncing off of each other process, they somewhat crush each other. So a crushing fracture is called a compression fracture. Again, common in vertebrae. So we can see over here in this x-ray of the vertebrae, we have a healthy vertebrae here, nice clean edges, no lines through the middle. In this particular x-ray, we can see edges, but we can also see lines running through the middle. So that means we've had some crushing and breaking apart of that particular vertebrae. The solution for that might be a little bit more surgical. They might go in and do some spinal fusion or some other work there if it's a major kind of thing. But even landing on your feet sounds good, not necessarily always the case. A spiral fracture is a twisting fracture. And this is a common thing in sports because in sports you've got a lot of rapid movement, very quickly transferring force from one part of the body to the other, and typically a lot of twisting and flexing. So as you can see in the picture here, it started to break or fracture at one point, and because there was a lot of twisting pressure there, it sort of started to spiral up or down the bone, breaking, sort of unrolling as you go. So relatively common in younger folks in the situations where you're doing a lot of twisting, a lot of rapid pressure transfer, and the bone sort of starts to break but uncoils itself in a way as it goes. An epiphyseal fracture we mentioned earlier with the idea that the epiphyseal plate was always going to be weak. So here we see very clearly that the diaphysis just broke right off from the epiphysis. And this happens to be at the knee, so what we're seeing at the top is the diaphysis of the femur coming down, and it just slid right off of the epiphysis there at the knee joint because of that slightly weakened section there. This might be because of a sudden stop of movement. Let's say you're playing tennis, and you've been lunging for that ball, and then you plant your foot on the ground and try to stop your entire body with one leg. Your entire body, with the laws of gravity and movement, says that, this is the law of inertia, it says that once an object is moving, it really wants to stay moving. So your lower leg says stop, the rest of your body says keep going, and if that epiphyseal plate joint is not strong enough to convince the entire body to stop, like the lower leg did, then the entire body might win and just shear it off right there. An ugly looking thing, but probably from the repair perspective not as bad as it looks. Let's jump to the green stick fracture here for this one. And a green stick fracture is very common in children, less common in adults because kids are more collagen, less mineral. So that means their bones are more rubbery. And a more rubbery bone, just like a green twig or a green stick on a tree, if you try to break a small limb, once the stick starts to break, it probably doesn't snap all the way in two because you've released the pressure. So one side breaks a little bit, the other side flexes, now the pressure is released and perhaps doesn't break all the way through. So more rubbery bones as a child means this is more likely of the kind of break that you're going to get. So it doesn't break all the way through. Again, quite common in children. Now, because children have that higher collagen percentage, because they are more rubbery boned, it means it takes a lot more force, typically, to break a bone. So if you go into the ER with a broken bone for your kid, hopefully they're going to provide good care for that child, but they're also going to take a look at the child, take a look at you, and start asking themselves some questions. And they'll probably ask you questions as well. And what those questions are designed to determine is, was this because the kid was being a typical stupid kid and jumping off the back of the couch or doing other self-destructive things? Or was this because you were beating your child? So unfortunately, a lot of times kids going into the ER, especially over and over again with broken bones, might be an indication of child abuse. So they're always going to assume that's a possibility and ask some questions. And if the hospital staff is not satisfied with the answers to your questions, the police department might show up and ask their own questions as well. This is one of those scenarios where you are assumed to be a guilty abuser until otherwise proven innocent. And unfortunately, that's probably an appropriate position to take. The last thing in the world we want to happen is to allow child abuse to continue. So it's better to be careful than to just assume it was a typical kid being dumb until you've proven that that was the case. Now, unfortunately, sometimes they get a little bit carried away with that as well and start jumping to conclusions before they really should. But that's just the problem we have in society. Because not everyone cares for their children appropriately, all of us are inconvenienced for the misbehaving of a few. And that's just, unfortunately, life. In this case, as it relates to young, rubbery bones. Our last type of fracture here is a depression fracture. This is typically a skull fracture. So what happens is a piece of the skull breaks and may become depressed or kind of press inward on the brain. Obviously, the job of the skull was to protect the brain. Now we've broken it, and a piece of that skull is pressing on the brain. That causes increased pressure on the brain. That then causes the brain to function abnormally. So hopefully none of you have ever broken your skull. Unfortunately, I have. And I can tell you it is a really inconvenient process. It was many years ago now. In the olden days, we had playground equipment that these days you're not allowed to have. These days, if you have a seesaw or a teeter-totter device, it's probably very short, and it probably has rubber mulch or a rubber pad under it, lest a child fall off and scratch their knee. In the olden days, there were no such concerns, and the thought was, kids are going to hurt themselves, let them have fun doing it. So in the olden days, a teeter-totter device was more like about 25 feet long, and then if you're on the up end, you're really up there. So I was on the up end, along with my younger brother, and this was probably a moment in Mom's history where she regrets having done what we did, but my brother and I were on one end, she was on the other. We were up, I fell off. I landed on the side of my head and neck. My brother fell on top of me, so he wasn't hurt because I've always been very cushioned and squishy. Unfortunately, fat does that for you. And so my head was damaged and everybody else was fine. But I immediately went blind. I couldn't see a thing because that pressure on my brain at that point was interfering with the visual part of the brain. Vision started to return relatively quickly, but for a while everything was a blur of color with no distinct shape to it. Vision eventually returned, but in the process we went to the ER, and they did some scans and some tests and things to make sure I was eventually going to be okay. At some point in that process I started vomiting, and that's a typical response to brain damage. That's basically the brain is a little bit freaking out and overreacting to things, resulting in nausea and vomiting. So that happened in the middle of the ER. That was great fun. I distinctly remember that I did not want to move. I didn't feel like moving and being up and around. And when they released me later that day, they did say, stay in bed. Give yourself a break here and let things heal themselves. Trust me, I didn't need to be told that. I'd figured that part out on my own. I didn't feel like moving, and I only got out of bed and moved when I absolutely had to, and there was no choice. You have to go to the bathroom at some point. So for a week, I stayed in bed and didn't feel much like moving. After about a week of that, I started feeling like moving around a little bit, but trust me, I very slowly eased into that process because I still didn't feel great. So it took a couple of weeks until I felt mostly normal again. So long story short, I broke my skull, depression fracture, and I recovered. Street language for a depression fracture is a concussion. So a concussion is some degree of a depression fracture resulting in some degree of brain damage along with it. I would like to think that I didn't experience significant brain damage that was long-lasting. Sometimes my wife might disagree with that, but I think that I pretty well came through it with no long-term effects. But it certainly was a very unpleasant experience that I wouldn't want to ever experience again. But like all the other issues, as long as that depression wasn't seriously pressing down into the brain, and that's what all the scans were for, is to make sure it wasn't seriously going to cause brain problems, it was roughly in place, it healed itself in a couple of weeks, and away we go. And to this day, I'm probably more hard-headed than I ever was before. Osteoporosis. The top picture here is normal spongy bone. The bottom picture is osteoporotic spongy bone. So what happens in osteoporosis is it's really a hormone imbalance. There are hormones that are telling the bones to put more calcium into the bone so that you replace what you took out and you maintain good, strong bones. When osteoporosis occurs, this typically occurs after menopause. And what menopause is a major hormone recalibration for the female body. It's resetting the body from a reproductive hormone cycles to a non-reproductive hormone cycles status. So up to the point of menopause, ovulation occurred roughly once a month. Menstrual cycle occurred roughly once a month, and that was hopefully a fairly regular rhythmic cycling of hormones up and down. Menopause resets that to stop menstruation, to stop ovulation, because it says you're too old to be even thinking about making a baby. Turn off your reproductive system. And that's all well and good, but the problem is in that recalibration, often the hormones that are regulating bone density and strength get off as well. And if those hormones are off in the wrong direction, you take out calcium as a normal part of daily living, but you don't put it back in. So what you see is the spongy bone slowly being degraded. It's being eaten by the osteoclasts as they release calcium into the blood, and the osteoblasts are not getting the signal to put the calcium back in. So the bones become weaker and more easily broken. When you go to the doctor and get a bone density test, they might come back and say it looks like you have osteoporosis, and basically they're measuring the density of the bone. And if the bone loses a certain amount of density, the assumption is that spongy bone is becoming extra spongy. At that point, they will suggest some things that you should do. They might give you some medications that will help to stimulate bone growth. Those don't work quite as well as the ads might suggest. But they will also suggest increased physical exercise, along with make sure you get enough calcium in the diet. So if you're not already eating a good calcium diet, the doctor might suggest calcium supplements. But for the most part, you could just consume more dairy product and get the same outcome there. But the physical exercise is really important because this is what was really the start of bone strength, was putting pressure on the bones, demanding performance of the bones. So if you become more physically active, that will be a natural stimulus, demanding more of the bone, and that will somewhat stimulate the normal process of let's put more calcium in here to increase the bone's performance abilities to then support what's being demanded of us. So increasing physical activity after diagnosis of osteoporosis is certainly useful. It will hopefully slow down the process of bone loss, but it's not necessarily going to undo it and cure it. But certainly slowing it down is a good thing. Probably most of you are at the point in life where you're not worried about osteoporosis yet, but now is the time to really do something about it. If you exercise a lot now, you will build strong, healthy bones now, so that when you get to the stage where osteoporosis might be an issue, if you're physically active and stimulating these bones to be strong and build themselves all along, you might actually be able to avoid osteoporosis. But even if you can't avoid it, you have gone into the process already with good life practices in place. So you're already being physically active on a regular basis, which will slow the progression. Also, if you went into it with larger, stronger bones, you have more bone available to lose, meaning osteoporosis can progress a lot farther before you actually have weakened bones. You had more there, so it takes more loss before it gets to a point where you notice a problem. So regardless whether you can prevent it or simply minimize its impacts, if you're physically active now when you're younger and stay physically active for the rest of your life, you'll not only have stronger, healthier bones that will last you longer, but all of your body will work better if you're more physically active for all of your life. So really, the closest we can probably get to the fountain of youth is being physically active now. For some of us, the idea of exercise is a foreign concept. It's almost inappropriate language for polite company to use the word exercise in a sentence. But if we would do probably more of it, we would probably be healthier. Here we have a different scenario. Here on the left, we have what is labeled as normal, healthy bone on that x-ray. I'm not completely convinced that it's as healthy as it needs to be, but it certainly looks better than the pagetic bone on the right. So this is Pacus disease, and with this, we really don't know a whole lot about it. But what we do know is that some areas of the bone, you can see the outer hip bones here, the bone is nearly disintegrated and gone. And in other places, let's say in the inside edges of the pelvic cavity there, it almost looks like the bone is more dense and strong than it normally would be. So what we have is irregular bone loss and irregular bone growth and deposition. So some areas are strong, some areas are weak, and it just becomes sort of a patchwork quilt of bone. We really don't know what causes it. We really don't have a whole lot of idea how to fix it other than the same response we would for osteoporosis, perhaps some bone building medications, a little bit more physical activity, and make sure you have plenty of calcium in your diet. And outside of that, we really don't know a whole lot about it. The good news is it's a relatively uncommon problem, so probably not going to run into that one an awful lot. And perhaps in some older folks, it might actually be Pacus here that gets diagnosed as osteoporosis. I suppose it really doesn't matter which of the diagnoses it is. The general treatment process is pretty much the same either way. Here we have a developing fetus. This is a 12-week-old baby, so this is 12 weeks of development, not 12 weeks after birth. And what we see is the beginnings of bones forming. So all of these started as cartilage, remember, and they're becoming bone. So what we see here is the ribs are relatively in place. The arms have all the bones there. They're not anywhere near finished yet. So we can see here in the arms, those bones need to get a little longer. They need to develop some more specific shape. In the hands and feet, we can see again, really a lot of growth left there to do. More so in the feet. So the hands develop first, then the feet. And mostly because the hands are what the baby's going to be able to use first. The feet are not going to be usable until much later in the process. So it's okay to get to those feet bones later in the process as well. The skull is all there. A little bit of reshaping is going to occur throughout the process. But interestingly, the clavicle is all there. It is completely developed and has its final shape. So why exactly would the clavicle develop so early in this process? And I don't necessarily have a great answer for that. Perhaps it has something to do with the clavicle being a useful and important bone in breathing. And obviously at birth, breathing is going to be an important functionality. So perhaps that's it. But outside of that, it's not going to have any great deal of weight-bearing function or anything else. It just is of interest, though, to note that of all the bones visible in this baby, the clavicle is the one that has experienced the greatest degree of development and completion. That wraps up Chapter 6 for us. So if you have questions, as always, ask those on the discussion board or in the live Zoom sessions occurring each Thursday from 11:30 to 12:30. And hopefully you learned a lot in this chapter and it was very useful. See you next time.